We've been dispatched at 9 a.m. to a female patient with a severe headache. The headache has come on over the last hour and was preceded by flickers in her vision. The patient has stated that this is her normal aura. The patient pain profile is described as a unilateral pain to the left side of her head and is described as intense throbbing. The pain does not radiate anywhere and nothing makes it better or worse. It's currently 7 out of 10 pain. She has slight photophobia and has no recent trauma to her head. She states this is her normal migraine symptoms, however the pain is slightly worse today. The patient has stated that she's been very stressed lately with her work. The sample history has revealed that the patient has a history of migraines, no other medical conditions, and has no allergies and is on no current medications. She has no history of intracranial bleeding or family history of cerebral vascular abnormalities. She has had normal food and fluid intake over the last week. The patient is systemically well and has a full set of vitals have been obtained and all within normal limits. I've also observed the patient to walk normally and she is fast negative. Okay, we're going to further assess the patient now. So are you comfortable where you are now?
Yes.
Okay, cool. Now we're just going to do a few more assessments on you just to make sure that your headache isn't anything more sinister than what we think it is at the moment. Is that okay?
It's fine.
Okay, cool. Now, have you been generally well lately? No colds, coughs, no sickness, nothing like that? No? Okay. Now, we're going to begin by assessing the patient's cranial nerves. So we've already ascertained that the patient has normal smell, we've had no change in speech, no change in vision, no change in hearing, and I've seen him to walk normally with a normal gait. Now, so first of all, I'm going to get you to open and close your eyes for me. Cool, that's good, and I'm going to get you to follow my finger with your eyes. Yep, so I'm just noticing that the eyes are moving together. Cool, and I'm just going to shine a little light in your eye, okay?
Okay.
Just look straight forward for me. Cool, so I'm just making sure that there's equal and opposite reaction of each pupil. Now I'm just going to test the sensation of your face, okay? So I'm just going to touch your face and you tell me if there's any change in sensation anywhere. No pain as well.
No.
No pain?
No.
Nothing around there? No. Okay, so I'm also noting while the patient is speaking that there's no slurring of their speech, there's no one-sided facial weakness or nothing abnormal. So could you just give me a big smile as well, show me your teeth? Okay, cool, so they've got normal symmetry of the face. Now, what I'm going to do now is if I could get you to shrug your shoulders to me. Cool, and I'll get you to move your head against my hand and down. This one. Cool, and I'll get you to squeeze both my hands. Cool, okay. Now what I'll get you to do is I'll get you to poke your tongue up for me and just put it each way. Yep, side to side, up and down. Cool, perfect. Alright then, now have you noticed any neck pain or anything like that?
No,
No stiffness in your neck? And if I
No.
press on the back of your neck there, is there any pain?
No.
No? Nothing on the side at all either?
No.
And you're able to put your head down to each side, touch your shoulder with your head. No pain when doing that in your
No.
neck? No? Okay, now I'm just going to teach you coordination, so I'll get you to use your finger on your nose. Finger, that's the one. Cool, so they got normal coordination. Alright, so now I'm happy with the physical assessment so far, so I'm just going to get my red flag, check this out, make sure I haven't missed anything. Okay, so the patient's had got no neck pain or neck stiffness, there's been no sudden onset of severe headache, they've got a normal temperature, no signs of influenza, there's been no persistent severe vomiting, no focal neurological signs, there's no altered level of consciousness or history of that with this headache. There's been no worsening of the headache following recent trauma, she doesn't take any anticoagulants, no signs of temporal arteritis, there's no hypertension during pregnancy, no previous history of intracranial bleeding, no family history of cerebral vascular abnormalities, and there was no onset during sexual activity. Also, this is the normal signs of the patient's migraine symptoms. It's just slightly worse than normal. So, I think that it seems to be that your symptoms are just a little bit worse than your normal migraine. So, I'm happy just to take you to the GP, just to you can see then maybe work out some better pain medication for the future if this happens again, or potentially something to help prevent this from happening as well. Does that sound good?
That's great.
You happy with that?
Yes.
Yeah, okay. So for pain relief, I would like to give you some paracetamol and ibuprofen. So you haven't taken any of those in the last 4 hours?
No.
No, and I've ascertained from before, there's no allergies. And so you weigh, how much do you weigh?
70 kg.
70, okay. So I'm going to give you 1 gram paracetamol, 400 milligrams ibuprofen. So I'll give you these and I'll go and call your GP. Okay, so I've just talked to your GP and he's happy to see you today.
Okay.
So because you are home alone here, I don't really want you driving there, so I'd prefer if we took you there. Does that sound good?
That's fine.
Yeah, alright, okay, we'll do that. Okay, so we've been dispatched to a 24-year-old male with a spontaneous nosebleed. The patient was at home watching TV when the bleed started. There's an estimated blood loss of 200 mils, which has happened over the last 45 minutes. All his vitals are within normal limits, and through a thorough assessment we've ruled out any hypovolemic shock. So he's got no allergies, he's got no medical history, he's taking no regular medications and is on no anticoagulants. He's had recurrent nosebleeds when in hot environments for the last couple of years. So he's eaten lunch today, and so he's had no preceding trauma as well. He's had normal fluid and food intake and normal bowel and bladder movements. So I've instructed the patient to sit with his head forward, holding the fleshy part of the nose for 15 minutes, and I'll place a cold pack at the back of his head. Okay, so we've reassessed the bleeding after 15 minutes and their nose is still bleeding, so I've advised the patient I want to give them intranasal adrenaline to help vasoconstrict the nasal blood vessels, and this is going to help stop the bleeding, and they've consented to this. So the treatment for this is 0.2 milligrams of IN adrenaline into the affected nostril. Alright, so now we're going to draw up our IN adrenaline. So to do that, we've got our drawing up needles, 10ml syringe, 5ml syringe, our adrenaline here, which has already been drug checked and is in date. We've got our sodium chloride and MAD device, also our sharps container. So to start off, we're going to draw up our saline. So we got 10ml syringe, get our sodium chloride. Now we're going to draw up 9 mils of this. Cool, so we've got 9 mil saline. We're going to pop a drawing up needle on the end, maintaining aseptic technique. And we're going to get our adrenaline. Pop that in the sharps container. So we're going to draw this up to a total of 10 mils of solution. That gives us a total of 1 in 10,000 solution. Pop that on there. Now we get our 5 mil syringe. Now we're going to draw that up to 2.2 mils. So we're going to be using 2 mils in our when we give the drug, and we just draw up a little bit extra just so that we can soak the MAD to stop any dead space. So we pop that on, get our MAD, put that on the end, and then we use that extra 0.2 mils just to soak the MAD. And now we're ready. Alright, so we've got our patient here. They've been holding their nose for the last 15 minutes while I've been drawing up this adrenaline. So Jacob, what we're going to do is we're going to assess if it's still bleeding, and then if it's still bleeding, we're going to put some adrenaline up your bleeding nostril, and hopefully that's going to help vasoconstrict those blood vessels in there and stop the bleeding. Alright, so we're going to have a quick look. We'll see if that's still bleeding. Yeah, okay, so it's still bleeding. We get to hold that again. So this is the device that we use. It's a mucosal autonosing device. So have a feel of that. It's just nice and squishy. That's going to go up your nose.
Yeah.
And so what we're going to do is you're going to blow out the clots first, and then I'll get you to tilt your head back, and I'm going to pop this up your nose and get you to take a big sniff, and I'm going to push it all into there, okay?
Okay.
Yeah, sounds good. So we'll get you to blow out those clots now. Awesome. And pop your head back, and now a big sniff, and push it fast. Awesome. Now I'll get you to hold that again. So we're going to hold that for 15 minutes, and hopefully that's going to stop bleeding. Alright, cool. So Jacob here has been holding his nose for the last 15 minutes now. So I'll get you to take your fingers off there, make sure it stopped bleeding. Looks like it's stopped bleeding now, so that's good. Now because it has stopped bleeding, I'm happy to leave you at home now. But I'd like you to see your GP in the next couple of hours, just because I have given you the adrenaline, and if that's all good. Yeah? Alright, so and just for next couple of days, make sure you avoid putting your finger up your nose. You don't really pick your nose, try not to blow your nose, try not to sneeze, don't want to take any hot showers or anything like that.
Yep.
That's all good. And you don't have any pain there at the moment, nothing like that?
Pain.
No. Cool. Alright, so what I'm going to do is I'm going to finish off my paperwork now, and then I'll leave you a bit of a plan to see your GP, and if you've got any sort of queries or anything like that, if it starts bleeding, just hold your nose again, or if it's really bad, you are able to call us back. Is that all good?
Yeah, it's all good.
Yeah,
Yeah,
sweet.
thank
So
you.
before I leave you home, I'm just going to go through a non-transport checklist to make sure that everything's all fine, haven't missed anything. Right, so it's 9 PM and I've been called to a 30-year-old male complaining of back pain. The patient suffers from chronic back pain, and yesterday, when he was moving some furniture around the home, he's picked up a table, it was a bit heavy and has hurt his back. This evening the pain is much worse than usual. After questioning the patient, I've learned he has no allergies, takes diclofenac as prescribed for back pain, and has a past medical history of chronic back pain. The pain profile is described as a dull ache around his lumbar spine, which is non-radiating, provoked by movement, nothing makes it better. It is described as 5 out of 10 severity compared to his normal 2 out of 10 pain. All vitals are within normal limits. Alright, so we're going to further assess Jacob's back pain now. So you're comfortable where you are now, Jacob?
Yeah.
Yeah, alright, so we're just going to have a bit of a closer look at your back and ask you a few more questions about it, alright? Yeah. So have you had any, is it just isolated to your back at the moment, that pain?
Yeah, just
Yeah?
front and lower back.
Yeah, okay. Do you have any chest pain or upper back pain at all with that? Nothing like that? Have you been generally well lately, no sicknesses, colds, anything like that?
No, I've been
No?
fine. Yeah.
You've got any altered sensation in your saddle area?
Not that I can tell. No.
Okay. You haven't been incontinent, lost control of your bowels or
No.
nothing like that?
No.
Okay. Have you got any altered sensation down your legs or funny tingling feelings, anything like that?
No.
No? Okay, cool. And you don't take any IV drugs, nothing like that? And what medication are you on? Are you on any immunosuppressants or?
No.
No? Okay, cool. Alright, Jacob, now I'm going to take a closer look at your back now, so if you could just roll over to your side. And I'm just going to lift your shirt up to have a closer look, okay? Alright, so I'm just looking at the back first. I can see there's no bruises, no discoloration, nothing abnormal on the back there. So I'm just going to have a quick feel down your back and you tell me where it's sore.
Yeah.
I'm just feeling down the spine. You tell me where there's pain.
A little bit down the lower side. Yeah.
Okay. Now I'm just going to feel down the muscles on the side.
Yeah. Yeah.
On the side? Yeah, okay. Just feel down your flanks as well. Any pain on those?
Nah, it's mainly in the middle.
Okay, cool. Alright, so it seems like the pain's isolated to the musculoskeletal area of his lumbar spine. So that's cool, Jacob. We'll get you to roll back over. Now, what I'm going to do now is I'll get you to lift your shirt up. I'm just going to feel your stomach, okay? So you tell me if there's any pain anywhere. No pain when I press on that?
No.
No? Alright, that's good. Get you to lift that back down. Now, I'll get you to straighten your legs out. Now I'm just going to feel down your legs and you tell me if there's any change in sensation or you can't feel anything. You able to feel that?
Yeah, it feels the same.
Yep. Cool. That's good. And you're able to pull your feet up against my hands. Cool. So normal strength and push them down. Cool. That's good. Now what I'll get you to do is I'll get you to lift your legs up and bend them at the knee. I'll just get you to hold your legs up there. You lift your feet up. Cool. That's good. Is there any pain when you do that?
No.
No. Cool. Alright, that's good. Get a light, put those back down now. And so there's no shooting pain or anything going down there or anything? Alright, so what we'll try now, if we could get you to sit up, and we'll see if we can get you to mobilise a little bit. That's all good? How's it feel?
It's not bad.
Not bad. So hopefully if we get a little bit more movement as well, we might be able to improve that pain. So looking at Jacob's gait, he's got a normal gait, he's walking fine. Is there any pain while you're walking?
No, I mean, it gets a bit better when I move around.
Yeah, okay, cool. Alright, very good. We'll get you to sit back down there. Now, I'm just going to run through a quick red flag checklist to make sure I haven't missed anything. At the moment, doesn't seem to be anything too sinister. I think it's just localized to your back there.
Yeah.
So we'll just have a quick run through everything else. So run through my red flag checklist. Had no loss of bladder or bowel control. You don't have a temperature over 38. You haven't had any rigors. You haven't got any abnormal vital signs. You've got no pain in thoracic spine or chest. Don't have any abdo pain or tenderness. No older sensation in the saddle area. No older sensation or power in both legs. You are able to walk. No signs or symptoms of generalized illness. Don't have any pain radiating down both legs. You don't have a history of cancer. You're not immunocompromised. Don't have any worsening pain when lying down. No recent unplanned weight loss. No older sensation. No pain radiating. No osteoporosis, and no IV drug use. Okay, so that's all looking good. Now, because I think it's just isolated to that back there, which could be related to your chronic back pain, I'm happy to leave you at home today. So what I can do is I can give you a bit of pain relief for all that now. Would that be okay?
Yep.
Yeah? So have you had any paracetamol or ibuprofen in the last 4 hours?
No.
No? And have you had tramadol before?
Yeah. Once.
Yeah, and you were fine with that?
Yeah.
Cool. And so you've got no allergies, so, and how much do you weigh, Jacob?
70.
70, cool. Alright, so I'm happy to give you 1 gram paracetamol, 400 milligrams ibuprofen, and 50 milligrams tramadol, so you don't have any confusion or dementia or anything like that. Okay, cool, so we're happy with that. So I'll give you those. And now, what I'd like you to do is see your GP either today or tomorrow, just sort of as soon as you can, hopefully get some more pain medication, something to keep on top of that back pain that you've got. And so just for now, if you want, you can take further paracetamol and ibuprofen in 4 hours.
Cool.
Yeah?
Yep.
That sound good? So you're fine with all of that?
Yes. Yep.
Cool. So what I'm going to do now, I'm just going to finish off the paperwork and I'll leave that with you. Then I'm just going to go run through another checklist with my crew member, and then we'll be happy to leave you. Cool. Cool. Okay, so we've stepped away from the patient. We're just going to run through our non-transport checklist. So the patient's been fully assessed, including full set of vital signs, appropriate investigations. No vital signs significantly abnormal. Serious injuries been excluded. No red flags are present. I've seen the patient mobilise, and the patient has also been able to be left with an adequate caregiver. We also completed our PRF and left a copy with the patient. Okay, so we've been dispatched at 9 AM to a 24-year-old male patient who suffered an injury to his knee during a basketball game. So he's fallen on the knee and he's had a sudden onset of severe pain in the knee. It's non-radiating anywhere. He suffered no loss of consciousness during the fall. So he's had some swelling which has come on over the last 30 minutes, which has been gradual. He's had no sudden swelling, so there's no reason to believe he's had hemoptysis. There's also some slight bruising on the lateral aspect. The sample history reveals he's got no past medical history, he's got no allergies, he doesn't take any current medication, he's been eating and drinking normally. We've taken a full set of vitals which are all within normal limits, and our secondary survey has revealed no other abnormalities. Alright, so we're going to further assess the knee injury now. Alright, so Jake, we're just going to have a close look at your leg, make sure there's no need to have an x-ray or anything like that, otherwise we'll transport you off to hospital, okay?
Mm-hmm.
So looking at your knee, we can see a little bit of swelling there now. How much sort of pain are you in at the moment?
Yeah. 5, 6 out of 10.
Yeah? Okay, cool. Alright, now I'm just going to check neurological deficits now, so we're just going to take off your shoe, alright?
Mm-hmm.
Alright, now if you, just going to feel down your leg and tell me you've got feeling down that side, can we touching there?
Yep.
And on there as well?
Yep.
I'm just going to take off the other shoe so we can compare it as well. Cool, can you able to feel that?
Mm-hmm.
And on the bottom?
Mm-hmm.
Cool. Now we can see both feet are equal colour, good colour, got cap read for 1 to 2 seconds, equal on both feet. Got a pedal pulse which I can feel equal on both feet there. And are you able to push on my hands? Cool. Able to push up? Cool, that's good. Right, so we've got good distal baselines. Now having a closer look at this knee now, I can see that you haven't quite got the dimple here on this side of the knee, whereas you do on the other one. So that's indicating a little bit of swelling there. So I'm just going to push up there to see what the swelling does. So we push that up. We can see it's kind of like quicksand going down there, indicating you've got a bit of swelling around the knee there. Now I'm just going to do a few tests now to see whether you will need an x-ray or not.
Mm-hmm.
So you just tell me if it's painful if I press on there.
Oh, yeah.
Yeah?
Yeah.
Bit of pain there? And if I press on there?
Yeah.
Okay. And I'm just going to tap on here to check the resonance. And I'm going to compare that to the other side. So it's a little bit more dull on this side, it's indicating there's a bit of swelling around there. Now I'm going to see if you're able to bend your knee to 90 degrees. So you just tell me when it's sore and we'll stop.
No.
That's sore?
Yeah.
Okay, cool. And so you weren't able to walk on it before at all?
I couldn't,
No. Okay, and you don't think you'll be able to take a few steps now?
No.
Okay. So with those factors that we've got the tenderness in the head of the fibula, tenderness in the patella, not able to bend to 90 degrees, also the patient being they're not over 55, so that's one good thing. However, they will need to have an X-ray due to that. Now, what I'm going to do now, I'm just going to check the ligaments in your knee here. So I'm just going to place my hand over here. I'm just going to put that to the side. So I'm just seeing if there's any excessive play, which I can't feel. So there's, I don't think you've got any ligament rupture on there. Now, what I'd like to do is give you a bit of pain relief, because we're going to have to get you off to hospital. So I'll start you off on some Internox, and then we'll get some more oral pain relief for you. So you don't have any allergies?
No.
Haven't been diving in the last 24 hours? No? Okay, cool. I see no respiratory difficulty, and you'll be able to go to the toilet normally? Yeah. Cool. Alright, so I'll give you some Internox, give that to you, and you can puff away on that along the rest of the ride. Also give you some oral pain relief. So have you had any paracetamol in the last 4 hours?
No.
No? Okay, no ibuprofen?
No.
No. And you've had tramadol before?
Yeah, once
Yeah, and
before.
that's all been fine?
Yeah, it's all good.
Yeah, cool. Alright, and you're under 80 kg, so I'm going to give you 1 gram paracetamol, 400 milligrams ibuprofen, and 50 milligrams of tramadol. And that'll help with the pain.
Cool.
So now to transport Jacob here, we're going to get him onto the stretcher, and we're going to just immobilise the leg here. We're going to make it as comfortable as possible. We'll put a few towels under here and just stabilise the leg with some towels on the side there, okay? That sound all good?
Yep.
Yeah, okay. So in doing that as well, we're going to recheck our distal baselines on the way to hospital too.